I'm Lindsay Yeh. I am a second-year OBGYN resident at UT Southwestern in Dallas, Texas. I'm here today to talk about one of our cases of a prenatal diagnosis of a fetal brainstem disconnection. The other names up here are one of our maternal fetal medicine fellows and one of our maternal fetal medicine attendings who helped me organize this case presentation this morning. So just to outline some quick learning objectives, so I would like to talk briefly about Dandy-Walker malformation and the negative prognostic implications of a brainstem disconnection within the findings of that syndrome. However, I recognize not everyone here is interested or, really deals with a lot of OBGYN. So kind of some more generalized points as well about the role of prenatal diagnosis and allowing for shared decision-making with patients and just allowing for informed care, as well as how prenatal imaging can inform delivery planning. So just a little bit of an introduction. So Dandy-Walker malformation, this is typically a diagnosis that's made prenatally on ultrasound. The key findings are fourth ventricle dilation in the brain that fills the posterior fossa, as well as cerebellar vermis hypoplasia. The phenotype of this disease is wide-ranging from cases that can be very mild. Oftentimes a stent is placed in childhood and then a child can go on to live a fairly normal life, versus extremely severe cases. There is a 15% mortality rate with Dandy-Walker malformation, but obviously a very wide array and a very wide spectrum of how this disease can look. In terms of brainstem disconnection, however, while Dandy-Walker malformation is actually a very common posterior fossa malformation, a brainstem disconnection is actually extremely rare, and it's when only a thin cord of tissue connects the superior and inferior portions of the brainstem. There are only 14 known cases of brainstem disconnection that I've been able to find in the literature, and so our case today represents what I believe to be the 15th documented case of a brainstem disconnection. So in terms of our patient, she was a 39-year-old G1. She was medically uncomplicated, no significant history, personal history or family history other than advanced maternal age. She had a relatively benign prenatal course initially. On a 7-week sauna was found to have a vanishing twin, but outside of that, nothing else super relevant. All of her serologies were benign. She was Rh positive, and she had a non-invasive prenatal testing done at 10 weeks that was low risk and showed a male fetus. So nothing significant there. It wasn't until her routine 18-week anatomy scan that findings consistent with Dandy-Walker malformation were seen. Biggest things were really that it showed bilateral ventriculomegaly and an abnormal profile, poorly defined nose, micronathia, several other findings that were consistent with Dandy-Walker malformation. At that point in time, an amniocentesis was performed to just get a better idea if there were any coexisting genetic syndromes that may have caused these findings. The amniocentesis was done at 19 weeks and was ultimately found to be entirely benign. Whole genome sequencing was undertaken, and there were no relevant variants that could be pathologically significant for the findings that were seen on sonography. At that point in time, an MRI was completed to just get better definition of the findings. Again, demonstrated findings consistent with Dandy-Walker malformation, and then also showed the torcula in the brainstem was cranially displaced, and again with those same facial findings. She was just being seen by an outpatient OBGYN in the community at that point in time, and it was at this point that she was referred to our maternal fetal medicine doctors at our academic medical center. We undertook extra review of the MRI, and then we also performed our own ultrasonography. Biggest things that we saw on our ultrasonography was that bilateral ventriculomegaly that we saw previously had actually increased. And so the bipyramidal diameter, or the space basically measuring across the diameter of the head, had significantly increased as a result of that ventriculomegaly. We also undertook, as I said, our own review of the MRI, and it was at that point in time that we discovered this brainstem disconnection. Again, a very rare finding, and also an indicator of a much poorer prognosis, unfortunately. So given the initial findings of Dandy-Walker malformation, as I said earlier, could range anywhere from, surgical procedures in childhood and living a normal life to very severe findings leading to extreme morbidity and mortality. And now having that finding of a brainstem disconnection, unfortunately, kind of pushing us towards the more negative end of that spectrum. Since we had all of this information prenatally, we were able to refer her to a multidisciplinary care team. We actually have a wonderful program called the Fetal Center that's co-run by a neonatologist as well as one of our maternal fetal medicine doctors. And the patient was able to meet with a pediatric neurologist, a neonatologist, our MFM team, palliative care, and really kind of highlight what were her goals for her own obstetrical care as well as the care of the baby given these findings that we saw. So shared decision-making was used and the patient ultimately opted for a comfort care only approach for the baby given the poor prognostic implications that we had seen on imaging. Throughout the remainder of the pregnancy, we undertook routine and serial ultrasonography. So every 2 weeks, we repeated an ultrasound. And over time, we saw again that bipyramidal diameter was increasing, meaning that the fetal head was becoming larger and larger. And so that obviously had implications for delivery planning. So when we see this large bipyramidal diameter, the first thing that's thought is that likely a vaginal delivery will not be able to be attempted just due to the large size of the fetal head. Moreover, even attempting a cesarean delivery, doing kind of our more routine low transverse uterine incision, meaning a horizontal incision across the uterus, may also not allow for enough space to deliver a large fetal head. And so going into that, we recognize that a classical cesarean may be necessary, meaning a vertical incision on the uterus. That carries a lot of implications for future deliveries. It puts a woman at a much higher risk of a uterine rupture due to the weakening of the tissue of the uterus. And so it's something that we try to avoid if at all possible. So going into the delivery, something that was discussed with the patient was a cephalocentesis, meaning a draining of some of that fluid that had accumulated within the ventricles. The patient ultimately accepted that. However, despite performing the cephalocentesis, that large fetal head diameter still was very limiting, and ultimately the patient did have to undergo a classical cesarean delivery. We also did this at 37 weeks gestation, a bit earlier than we would have otherwise, just given the fact that we kept seeing that bipyramidal diameter increasing and increasing, knowing that that would likely only necessitate, more heroic measures at delivery in the future, given the large size of the fetal head. So ultimately, a classical cesarean was done at 37 weeks after a cephalocentesis. The baby was born, unfortunately, with APGARs of 1 and 1, was found to have no obvious respirations, very bradycardic to the 60s, and the infant unfortunately passed away about 35 minutes after delivery. Grossly, there were findings of Dandy Walker malformation with severe macrocephaly, sunken fontanelles, micrognathia, cleft lip, etc. In terms of our patient, she did have a postpartum hemorrhage likely due to the overly distended uterus due to the large size of the fetal head. This was treated with uterotonic agents and TXA, and otherwise she did really well. So overall conclusions. So obviously a very interesting case given that this is only the 15th documented case of brainstem disconnection and significantly worsened the prognosis of the patient. However, I think what's very interesting is that given that we were able to diagnose this prenatally with sonography and MRI, it really gave us the opportunity to empower the patient to make decisions for herself and the baby ahead of the delivery, and ultimately allowed for palliative care to be very involved, for the patient to do some memory making around the time of delivery and things like that that may not have otherwise been possible. Those are my references. Thank you so much. Does anyone have any questions? Yes. Yeah, that's a very interesting question. So I believe it's the second reference on this slide, actually undertook a comprehensive review of the 14 known cases. And so there's two main theories as to the pathogenesis of brainstem disconnection, one being vascular and the other one just being congenital brain malformations. This seemingly falls into the congenital malformation camp, given that she had the findings of Dandy Walker malformation. However, what's interesting is that in that second paper, one of the authors actually proposes a vascular mechanism for brainstem disconnection being the presence of a vanishing twin early on in pregnancy. And that was actually seen here. And so that's never been known. That was just something that was theorized actually by the author in the second paper. But I think it is something interesting to think about is, could that have played a role in the brainstem disconnection? So hard to say exactly what the risk factors are with there just being such a paucity of data, but I think that is something interesting to think about.
her advanced maternal age had anything to do with it, or less likely?
I think less likely. I mean, obviously, anytime we're talking about advanced maternal age, we start thinking about things like non-disjunction of chromosomes and things like that. But as I said, her non-invasive prenatal testing was entirely negative, so no evidence of any trisomies. Typically, we look at 13, 18, and 21. And then we also undertook that whole genomic sequencing after the amniocentesis, and there were no pathogenic variants that could be related to what was seen here that we know of. So I would say probably not, given that the mechanism of most conditions that are induced by advanced maternal age is that chromosomal non-disjunction, and we couldn't find any evidence of any genetic malformations here, but certainly could be possible.
I know you mentioned that this particular neonate was a male infant. In your literature review and everything, did you notice that there was, are you aware of any association or correlation between male gender or things like hydrops also going with?
That's a really interesting question. From what I could see, again, in those 14 known cases in that second reference there, it seemed to be, I don't remember if it was exact 50-50 split, but there were certainly both male and female babies that had been affected by this condition. And then interestingly, I think it's also in that second paper, there was a case of actually a female infant with a brainstem disconnection that's been known to survive past birth actually into the first year of life. So just an interesting case there as well. Yeah.
Any other questions? All right. Well, thank you so much,
Great,
Dr. Yeh.
Thank you.